I think that's where the future chronic care disease model is going to go. Information used intelligently.
You work in a very large hospital. From an organizational perspective, do you think that healthcare institutions can put together structures that can facilitate that behavioral modification for patients?
It's a really good concept, and I believe that's going to be the core of delivering future medicine. So we often use the term personalized medicine to personalize based on biomarkers. So if I know if I can measure serum rhubarb or measure something in somebody's breath, I kind of know what drug to give them. But making them take the drug, or also to making sure that I prescribe the right drug, because that's the other issue. There's no point being adherent when the doctor's under-prescribed the medicines or over-prescribed it so the patient gets the side effects. So it's a real art in making sure that your desired outcomes are suited, so your dosage and your drug is tailored to the desired outcome. So that's really, really important in terms of delivering that in the same way. But we recognize, certainly in the COVID pandemic, has really pushed us into understanding patients, but also how do you use digital in every way. And we know this from every healthcare organization who's adopted different innovations and techniques post-COVID, because they've been forced to do that. One of the things we now are doing is virtual consultations. So it's very rare for us now to see patients face-to-face at the moment. So how do we use remote digital communication forms to try and get the same message across as well? Patients prefer it, but part of this is that whenever a patient has a journey or an interaction with a healthcare professional, we mustn't use digital to replace that conversation. I think it's important that we use digital to enhance the quality of that conversation. How do we do that, you may ask? Well, there's loads of ways. So one of the things I would love to know in my patient is that maybe I don't want to spend 30 minutes trying to extract this information when actually the patient is much more willing to give it to some chatbot, and that information is uploaded and that information is then available to the clinicians so they can get off to the right degree of quality consultation. But also, can we then use information that will allow us to get the maximum benefit from the inhaled treatment? So using asthma as an example, if I was to be able to screen a patient digitally about where they are with their adherence phenotype, so I would call it a phenotype, whereas you get the biological phenotypes, my adherence phenotype might be quite different. And how you phenotype these patients, well, there's a real science behind that. But one of the ways I'd love to do is patients to be able to declare their stories. What are their stories that driving most of their concordant, or in most cases, a lot of cases, discordant behaviors. So we know it'll be around beliefs, concerns, and other issues, but how do we extract the belief forming issues, but also how do we then get into the habit that then attaches itself? So if I knew that my patient was, looking at the weather on their app every morning, if their internet tells me that the first thing they do every morning is look at their app or something, or Google search or whatever, or find out what the previous night's baseball or football scores were, great. Can we use something like that in order to attach a habit-forming behavior in that same way? So using information that is part of a patient's lifestyle is critical for us to then do the right thing for them. So I think understanding adherence phenotypes, attaching it to behaviors, and then allows the clinician that information to give the right supporting package, because the same support package will be different from one patient to another. So going back to the earlier point, heterogeneity in adherence, we need to have different interventions for different types of adherent behaviors. And it's complex, certainly in my area as well. So going back to that future of medicine, if a patient was to walk into a hospital, I want to know, for example, the demographics, great, got that. I want to know what comorbidities, what medicines have been prescribed. I want to know what their BMI is. I want to know what their adherent behaviors are like. I want to know what their adherence is like. At the moment, we don't do that. Patient comes in with an asthma, you treat them, and off they go. But if I had intelligent systems that tells me, as part of their lung function and their X-ray and all the other information, their adherence risk, or maybe their spur profile, Kevin, something that tells me where the person is in base of risk. So use that opportunity to try and modify the behavior rather than just prescribe the drugs and get them out the door like a Formula One car. Spend a bit of time, try and understand them, and then move them on that way. So everything around social interaction, comorbidities, physiology, biology, if we can stratify that together, and then here's a crux of it, if you can build an artificial intelligence system that will allow that amalgam of that information to then prod and nudge the clinician, say, in this situation, these are the things you might need to address. It'll allow us a better opportunity. So I think that's where the future chronic care disease model is going to go, information used intelligently.